Welcome everybody to this session on thyroid eye disease. My name is Thomas Hardy. I'd like to start by the Royal Australian and New Zealand College of Ophthalmologists members and participating guests. We all wish to acknowledge the Aboriginal and Torres Strait Islander peoples of this country, sovereign custodians of our country. We acknowledge their continuing presence and their contribution made to the college and communities that we work in. We will respect past elders and communities and will continue to live, work and interact in a respectful manner with present and future elders and communities. The RANZCO Reconciliation Action Plan reflects the messages of its First Nations engagement. As I said, I'm Thomas Hardy. My co-chair is Jwu Jin Khong, and we have a panel of fabulous speakers for you this afternoon. So I would first like to introduce Professor Timothy Sullivan, who's a Professor of Ophthalmology at the University of Queensland, a leading researcher who's published well over 150 papers and book chapters. Tim is a popular keynote speaker, particularly in relevance to thyroid eye disease. He's made recent presentations on thyroid orbitopathy, the changing paradigm in 2017, and thyroid eye disease in paediatric population. He's a regular speaker internationally and a very entertaining chap, and I'd now like to introduce Tim to the podium. Thank you. Oh, sorry, I almost forgot one more question, one more point. If you could also use the Congress app so you can submit your questions via the app and put your devices on silent. Thank you. Thanks, Tim. Try to advance. Yeah. That one. That back. And laser pointer there. Or there's a mouse.
Yeah. Thanks, Tom. I'm not sure how many of you were at the oculoplastic session yesterday, but it was quite interactive and there were exciting cases, and I find that instead today I'm basically doing Journal Club, presenting a couple of papers. But what's actually different from Journal Club is these are three really important, exciting and pivotal papers that will probably change the way thyroid eye disease is managed. And it's not just about Teprotumumab, but there are a lot of other exciting things going on as well that will probably unfold in the next few years. So we all know about the pathogenesis of thyroid eye disease and the TSH receptor and the IGF-1 receptor interacting and activating CD34 positive fibrocytes with a number of different B and T cell reactions and inflammatory cascades. There's a sort of a break on the system with SLIT2, and it's here that Teprotumumab may have an important role. This is a human monoclonal antibody inhibitor of the IGF-1 receptor, and it was actually originally developed by Roche for oncology as an anti-tumour agent, but it had issues and failed efficacy in the sarcoma studies, and so that got buried, and years later it was repurposed for thyroid eye disease following Terry Smith and Ray Douglas's work. And it's interesting, it's gone through phase 3 studies and over the years from 2014, 18, to 20, such that it is actually now FDA approved and it's first-line treatment in the United States. But the rest of the world does not have access to this medication at the current time. And the three studies which really anchored its place are the Teprotumumab for thyroid-associated ophthalmopathy, published in the New England Journal in 2017, which was a multi-centre, double-masked, randomised, placebo-controlled trial with 112 people enrolled or screened, and eventually 45 got the placebo and 42 got the Tepro. And this is sort of the bottom line. The onset of response was at about the 10-week mark for Teprotumumab. It had a protracted time course, and the response in the right-hand slide shows that the Teprotumumab had a much greater response than the placebo, such that 70% of the Tepro patients improved compared with about 20% of the placebo patients with a high degree of statistical significance. And in those patients who had imaging, you could see that there was actually a decrease in the orbital fat volume, decrease in the extraocular muscle volume, with very impressive clinical appearance improvements, as we can see the placebo patient in the top frame and the Tepro patient in the bottom two clinical pictures. And then we move on to now what has become known as the Optic trial, which was again published in the New England Journal a couple of years ago, 2020, with 13 centres across the States and in Europe. And this was again a randomised double-masked placebo study, looking at people who were either given a number of infusions of Teprotumumab, which you can see on this slide, or placebo, and they were assessed 3 weekly for 21 weeks, and again at the end of the study at 24 weeks. They included people between 18 and 80 with a diagnosis of Graves' disease, with active, moderate to severe thyroid eye disease, and a clinical activity score of at least 4. They excluded people who had surgery or radiotherapy to their orbits, or suggestions of optic neuropathy, or an steroid dose greater than a gram of methylpred, or who had had other immune modulators such as tocilizumab or rituximab. And their primary outcome measure, and this was directed actually by the FDA, was a proptosis response. They just wanted a very simple measure, and they set the bar at 2 millimetres at 24 weeks. Various other secondary outcome measures which are listed were also included. Interesting to have a look at the smoking status. They did include smokers in this study, which with small numbers could confound the outcomes, but the smokers and non-smokers were pretty much evenly distributed in both arms, and so it didn't make a big difference. This is a breakdown of the study design, which is a little bit clumsy to look at, but essentially 41 received the infusions of Teprotumumab, and 42 had the placebo. And if we look at the primary response, 83% of the Tepro patients responded, compared to 10% of the placebos. And similarly, there were similar percentages for the overall response, CAS score, change in proptosis, diplopia response, and interestingly, the quality of life score also dropped by a significant number of points, with the p-value basically less than 0.001 for all of these categories, which is pretty impressive. And looking at a linear representation of this, the Tepro patients are the dark line and the placebos are the grey lines. And you can see that there is a very wide disparity between these two groups. One of the ones that's interesting to look at is bottom right, which is the quality of life. So everyone in the study thought they were onto a good thing at the 6-week mark. So the placebos, they actually had an improvement in their quality of life, but when they realised they were just getting the placebo, everything went downhill again. And those who had imaging, as I showed in that earlier picture, had a decrease in fat volume and muscle volume. There were generally mild adverse events, 2 serious ones, including an infusion reaction, which resulted in the drug being discontinued. And these are listed here in the paper, which you can read. And they're things like muscle spasms, alopecia, fatigue, and what they haven't listed there is hearing loss, which has come to be an issue subsequently. And the conclusions were that with patients who have active thyroid eye disease, that Tepro resulted in better outcomes than placebo, which we all know now. And from that Optic study, they then thought, well, we'll extend this and we'll look at the people who were non-responders in the placebo group, or people who had a flare, and which I've just mentioned. And it was an open label study, and there were 37 in the non-responders group, and most of those were non-responders, but they had a small number of people who did respond in the placebo group, and there were a couple of those who had a flare who were also included, whereas in the Tepro group, they were mainly people who, obviously they had responded, but they had a flare, and that's why they were included. And they gave these people 8 infusions of Teprotumumab, as listed there, and assessed them over that same 21-week period with a final result at 24 weeks. And this is a little breakdown of the design of the study. Here we had, I think it's 34 patients in the non-responders, as well as someone who responded but had a flare, leading to 36 people in the placebo arm, whereas in the Tepro group, they had a small number of non-responders and a larger number who had a flare. I can't quite get all these numbers to add up, and I couldn't sort of see that in the methods of the paper, but nonetheless they went on to have a statistical analysis that seems to be effective, such that of the people who did not respond initially to their placebo, 90% of them became proptosis responders when they were actually given the Teprotumumab infusions. And then when they looked at the Tepro non-responders who were retreated, that is, they were given more Teprotumumab, 2 of them responded, 1 showed a mild proptosis reduction, and 2 discontinued the treatment. And of the Tepro people who had flares, about 2/3 of them responded when they were retreated. And this is the graphical representation here of the Optic study compared with the Optic-X study. And the Optic study with Tepro is the blue line, and the Optic-X study is the grey line. And what we can see is that both of those, the patients who had a prolonged treatment on the Optic-X trial mirrored the response rate of the original Tepro study. So, in conclusion, patients with thyroid eye disease of longer disease duration responded similarly to those who were treated earlier in the disease course, and those who had an insufficient initial response or flare may benefit from additional Tepro. And they didn't identify any new risks or no real further safety-related issues. These were the main trials that JJ wanted me to discuss with you, but there's a burgeoning literature on Teprotumumab and other agents, which I think JJ is going to come to now, looking at patients with active new onset thyroid eye disease, more heterogeneous groups, chronic ones, people who are reactivated, dysthyroid optic neuropathy and asymmetrical disease. And all of these seem to have a good response to Teprotumumab. But meanwhile, it's available in America, but not available here. So let's see how the rest of the symposium goes. Thank you.
Thanks, Tim.
Thank you very much, Tim. I'd now like to introduce Jwu Khong, who holds a PhD in thyroid eye disease. She is a research fellow at the Centre for Eye Research Australia in Melbourne. She's on the ethics committee at the Eye and Ear. She holds 3 public hospital appointments, including the Orbital Clinic at the Eye and Ear, for which we're extremely grateful, the Royal Melbourne Hospital Clinic, for which I'm personally very grateful, and the Austin Hospital. And JJ is going to talk today about advances in medical treatment, new treatment trials in thyroid eye disease. Thanks, JJ.
Thanks, Tom. Firstly, I have no financial interest to disclose, but I do want to disclose that Valencia Bio and Viridence are sponsors for clinical trials in thyroid eye disease that we'll discuss today. In the last 5 years, we have seen a clear shift in TED medical treatment guided by clinical trials. We have also witnessed an exponential growth of bioengineered, fully human and humanized monoclonal antibodies that is used in oncology, autoimmune diseases, which now has a flow-on effect into the field of thyroid eye disease. Thyroid eye disease medical management has entered a new era of precision medicine. This is an overview of the number of thyroid eye disease clinical trials registered in the US Clinical Trials, EU Clinical Trials Registry, and an ISR-CTN registry every year. The earlier clinical trials on thyroid eye disease in selenium, azathioprine, rituximab, mycophenolate, and tocilizumab has already made an impact in the management and increased the choices of medical treatment for thyroid eye disease. Teprotumumab trial was registered in 2014, which has become a landmark advancement in TED treatment as a first drug that effectively reversed proptosis and improved double vision. Since 2015, many more interventional trials in thyroid eye disease are planned and are currently recruiting in phase 1 2, and 3 clinical trials. So let's look at what are the changes in medical treatment for the active, moderate to severe thyroid eye disease. While the first line of treatment remains as weekly pulse intravenous methylprednisolone treatment for many parts of the world, medical management is shifting towards increasing use of immune modulators to address the immune dysregulation in TED, with early addition of mycophenolate. This is based on the result of 2 randomized control trials, one showing a high response rate with CAS reduction and double vision improvement, and the Mingo trial that shows a less dramatic response, but showing similar trend of better outcome at 6 months and 9 months and reduced reactivation as compared to systemic corticosteroid. Tocilizumab has carved a role in the progressive active thyroid eye disease cases, especially in the steroid non-responder. RCT shows superior response in CAS reduction and inactivation of inflammation by week 16. Rituximab may have a role in refractory cases based on open-label studies showing superior inflammation suppression and in some cases, reversal of DON cases. Its role in the active, moderate to severe group somehow needs further exploration through larger clinical trials. Teprotumumab has become first line in some parts of the world, predominantly in the US, as we have heard Tim's analysis on teprotumumab efficacies, but access and cost remains an issue for the rest of us, while we also await further post-marketing data on its efficacy, reactivation rate, and the long-term safety. Based on the outcomes of these early TED trials, at the Royal Victorian Eye and Ear Hospital, we have adopted the following in our treatment protocol for the active, moderate to severe group. We would recommend weekly IV methylpred as per UGOGO guideline as the first-line treatment. At 3 weeks, we check for early response. That is, by having either CAS reduction by 2 points, or improved extraocular movement by 15 degrees, or proptosis reduction by 2 millimeters. For patients who are partially or minimally responsive, we would then add mycophenolate early on for at least 6 months and complete the course of IV methylpred. Despite this, some patients will still have rumbling inflammation, and these are considered for orbital radiation. Patients who progresses despite these measures are referred for tocilizumab infusions until teprotumumab becomes more readily available to us in the future. For patients who have reactivation disease beyond 3 months of the initial IV methylpred infusion, we would consider a second course of IV methylpred with mycophenolate concurrently. So what is new in TED trial? As the pathogenesis of thyroid eye disease is better understood, new treatment for TED become more precise. This slide is prepared by Michael Wachno, a medical student who was doing his MDRS research project with me. It summarizes the new and existing molecular targets for therapies currently under trial in active thyroid eye disease. The anti-TSHR and anti-IGF-1R target these specific antigens on fibroblasts. And the anti-neonatal FC receptor targets the recycling of Graves' disease IgG. These drug classes have the potential to mitigate the immune trigger for both Graves' disease and thyroid eye disease. Other emerging treatments are I have to go back. Excuse me. Okay. Other emerging treatments are focused on suppression of inflammation, vascularization, and fibrosis. Anti-VEGF-A in the form of aflibercept is trialed as a sub-Tenon injection. mTOR inhibitor, sirolimus, targets the mTOR pathway. By inhibiting interleukin-16, it has also shown anti-fibrotic effect in vivo. Anti-IL-6R with tocilizumab is currently on trial as TOGO trial, a new head-to-head comparison between tocilizumab and IV methylpred. Anti-IL-17A with secukinumab is trialed in the ORBIT trial. And anti-BAF, anti-CD20 aims to deplete B cells and the production of pathogenic antibodies. You will note that just over half of these new treatments trialed in thyroid eye disease are monoclonal antibodies. In the last 12 months, we see the outcome of the STEGO trial. STEGO trial is a phase 2 single-center open-label trial in active moderately severe thyroid eye disease with raised low-density lipoprotein. Patients were randomized to either receive atorvastatin and IV methotrexate or IV methotrexate alone. The overall response rate at 24 weeks was higher in the statin group at 51% compared to 28% in the non-statin group with a small attributable risk. Interestingly, the response rate was much lower than expected compared to previous IV methotrexate trials. The quality of life was higher in the statin group, and relapse rate was also significantly lower in the statin group. I think the take-home message of this study is it implies we should check the cholesterol status of our thyroid eye disease patient and refer them for treatment as required. There is another statin trial happening in Sweden, which compared simvastatin with no treatment in the mild to moderate thyroid eye disease group. And we'll also await the result of this statin study. Ki-70 is a fully human monoclonal antibody against TSH receptor. The blocking effect of Ki-70 was demonstrated in vivo and in animal studies. This led to a phase 1 human trial in 18 Graves' disease patients in a multiple ascending dose study. Some participants had thyroid eye disease. They were chosen if they have inactive disease and they do not have dysthyroid optic neuropathy. The study showed that Ki-70 was safe and was well tolerated at all doses, and there was no report of serious adverse reaction. There was a significant dose-dependent induction of hypothyroidism with higher doses of Ki-70. It occurs as early as day 28. The outcome of TED patients also appear promising, with 5 of the patients showing proptosis reduction ranging from 1 to 8 millimeter. Rozanolizumab and batoclimab are monoclonal antibodies against neonatal Fc receptor, which are present on dendritic and macrophages. Neonatal Fc receptor, it binds and returns IgG back to the cell surface, therefore inhibiting Fc receptor degradation. Therefore, if you block Fc receptor, it has a net effect of increasing degradation of unbound pathogenic IgG, and it reduces the availability of this autoantibody. Rozanolizumab has completed a phase 3 trial in generalized myasthenia gravis and achieved positive outcomes in terms of improving the scoring of activity of daily living, and with more than 70% reduction of IgG. But this has not yet been trialed in thyroid eye disease. Batoclimab, however, had gone through phase 2 trial in TED. The study program was terminated early in phase 2 due to a need to unblind treatment arms. The available phase 2 results shows significant reduction in both TSH receptor and total IgG in the higher dose treatment groups. They've also shown a 30% proptosis reduction of a trending significance compared to placebo. Currently, batoclimab has entered a phase 3 trials for both myasthenia gravis and thyroid eye disease. Now, the next generation of IGF-1R monoclonal antibody have higher binding efficacy to IGF-1R than Teprotumumab. It has a higher potency through half-life extension. It thus affords reduced dose and frequency of dosing with the convenience of a subcutaneous injection. The current pipelines in this category include VRDN1, 2, and 3 by Viridian and VB421 by Valenza Bio. The early data for VRDN1 were compelling for both safety and efficacy. In the phase 1 safety study, given as 2 infusions 3 weeks apart, The trial drug was well tolerated in all subjects. At 10 milligrams per kilogram, there was no serious adverse effects, and there was no patient discontinuation, hyperglycemia, or infusions reaction. At 6 weeks, the following clinical efficacy was observed. There was an 83% overall response rate with 83% proptosis reduction of more than 2 millimeter. There was rapid disease inactivation with a mean reduction of CAS score by 4.3 points. For patients with double vision at onset, there was a 75% complete resolution of double vision. All VRDN1 efficacy measures compared non-inferiorly and favorably to Teprotumumab. MRI further highlights the reduction in ocular muscles volume after 2 infusions of VRDN1 as a driving mechanism for proptosis reduction. The promising safety profile and the early efficacy data observed with VRDN1 give us the confidence to join as a lead study site in Australia. We will be bringing VRDN1 trials to your patients with active thyroid eye disease next year. The VRDN2 trial will be administered as subcutaneous injections. VB421 is a humanized monoclonal antibody. This medication, this compound has the highest binding affinity to IGF-1R in the anti-IGF-1R drug class. Preliminary data from phase 1 trial suggests that the ascending doses were safe and were well tolerated in the healthy subjects. VB421 will be recruiting 3 cohorts of TED patients at 8 to 12 patients for each dose level, which is given as 2 subcutaneous injections, also spaced 3 weeks apart, and participants will be followed up for 16 weeks to assess the safety, pharmacokinetics, and the drug efficacy. I am pleased to announce that CERA will be the lead site in Australia, and we will be joined by Brisbane, Sydney, Perth, and Adelaide for the Valenza Bio VB421 trial. As a group of oculoplastic doctors, we are excited that our patients will have access to the new IGF-1R monoclonal antibody, and we plan to recruit participants as early as February next year. The top inclusion criteria are that the patients have a clinical diagnosis of Graves' disease and active moderate to severe thyroid eye disease. The onset of the active disease is within 24 months, and they have proptosis above the normal range for race and sex. The top exclusion criteria include having previous orbital radiation and surgical treatment for thyroid eye disease, or if the participants have poorly controlled diabetes. Patients will have to stop smoking prior to entering the study. I think this exclusion criteria will send a strong message to our patients about the importance of not smoking. Hearing will be screened with the audiology test, and patients with tinnitus, orthophony, or hearing impairment will be excluded from the study also. Corticosteroid use with a cumulative dose of more than 3 grams at any time, or more than 1 gram within 8 weeks, and any systemic steroid use within 4 weeks will also be excluded from the study. We have started a thyroid eye disease clinical trial registry. For eligible and interested patients, please send your referral to CERA trials at trials@cera.org.au. The trial coordinator will keep a record and provide patients with further information when the trials commence. With that, I thank you for your attention.
Thanks very much, JJ. Would you like to stay there and introduce Tim? Thank you. We have another Tim.
Right. Now I'd like to invite Dr. Tim Godfrey, the head of Ocular Rheumatology Clinic at the Royal Victorian Eye and Ear Hospital. The OPEL unit and the EORC units form a multidisciplinary team in co-managing the thyroid eye disease patient. He is also a co-investigator for the thyroid eye disease clinical trials. So let's welcome him to talk about the medical consideration, cost, and access to immunotherapies for our patients.
Thanks, JJ, for the invite to attend this symposium. These are my disclosures. I've got no financial disclosures, but obviously I'll be discussing off-label use of medication, and I don't claim to be an expert in thyroid eye disease. At the Eye I'm a jack of all trades, running immunosuppression for a large number of conditions. I thought I should remind myself of the extent of the problem, that most patients with Graves' disease or thyrotoxicosis don't get ocular involvement, and it's only 5% of thyroid eye disease that ends up being severe. And I tend to be referred those patients that have failed steroids, so I do tend to see a very biased end of the spectrum. And what I'm going to talk about today is very much a rheumatological aspect of this. And to prescribe immunosuppression for these patients that have failed steroids, ideally I need to know that the disease is active and not just severe proptosis with fibrosis. And assessing thyroid eye disease activity can be difficult. The clinical activity score has been criticised as being too binary, subjective and lacking in sensitivity, poorly designed for monitoring improvement or progression. And as you're aware, other proposed methods may not reflect disease activity, such as binocular single vision mapping, measurement of proptosis and Hess charts, and they may just be reporting damage, again, rather than inflammation. Serial TSH receptor antibody levels, although correlating in many studies with clinical activity scores, they don't always correlate with activity. And that brings us to MRIs. And there's been a number of studies that have looked at MRI outcomes, and it does look as if using stir images and fat suppression that we may be able to, with MRI investigations, detect those patients with ongoing active disease. And I was particularly interested in this study out of China last year, talking about using MRI, and they studied 161 patients and used a deep learning technique to identify objectively those patients with ongoing active disease. And maybe that's part of the way of the future in assessing these patients. We know in rheumatology that treating early influences outcome in some of our disease, particularly for rheumatoid arthritis and also for conditions like lupus and lupus nephritis. And so I do wonder whether, if we treated patients with thyroid eye disease earlier with traditional treatments or immunosuppression, whether we would get better outcomes. And the other question I had was, how good are endocrinologists at detecting thyroid eye disease? And looking at the literature, I wasn't able to find good literature on this to say whether endocrinologists are referring patients to ophthalmologists late in the piece or whether they are attuned to the condition and refer early. So is there evidence that treating early in thyroid eye disease influences outcome? Well, there are a few studies in looking at response to radiotherapy that showed duration of thyroid eye disease less than 6 months was a predictor of better outcome, and the same in intravenous steroids treatment, that the outcome seems to be inversely related to disease duration. We're all familiar with the European guidelines for treatment of thyroid eye disease, recommending intravenous methylprednisolone at 500 milligrams for 6 weeks, and then subsequently 250 milligrams for a further 6 weeks if there is a response. They changed the guidelines in 2021 to include the use of mycophenolate, and I must admit they used very low dose of mycophenolate, and they evaluated outcome at 6 weeks. And normally I tell patients it takes up to 6 weeks before we see an effect. And at a dose of 360 milligrams BD of My40, it's quite a low dose. And I always like to use doses of immunosuppression to the fullest so that I know at the end of the time that I've given them a decent dose of the medication to judge response by. So are there any contraindications to using intravenous steroids? Well, recent hepatitis, liver dysfunction. In one study, 5 times the upper limit of normal of transaminases was a contraindication. If patients have significant cardiovascular morbidity, you should be cautious. Severe hypertension, obviously poorly controlled diabetes and glaucoma, hypokalemia and active infection, including untreated latent TB, would be contraindications. We know liver injury occurs with steroids, and it is a risk factor with using pulse methylprednisolone for treating thyroid eye disease. And we certainly can see exacerbation of chronic viral hepatitis, both hepatitis B and C, with using intravenous methylprednisolone. But what appears to be unique to methylprednisolone is that it can result in acute liver injury, and there have been occasional deaths reported, particularly when doses over 8 or 10 grams have been used. This is one of my patients recently that I've treated this year, that she was doing fine up to about 8 pulses of methylprednisolone, but after the 9th, her ALT peaked at 811 for no obvious explanation apart from the intravenous methylprednisolone. So this slide's a bit tongue-in-cheek. Should ophthalmologists prescribe prolonged high-dose steroids? Well, I have to justify my position at the eye and ear. But I'm a big supporter of Ted Lasso. I like Ted Lasso, and he commented on taking challenges is a lot like riding a horse, isn't it? If you're comfortable while you're doing it, you're probably doing it wrong. And I feel the same way about using high doses of steroids, particularly for prolonged periods. Particularly with oral steroids, I see weight gains, 20 to 30 kilograms in some patients. My young lupus patients occasionally end up with hip joint replacements for avascular necrosis. So it's not a drug that I feel comfortable about leaving patients on in high doses for prolonged periods. And this is some of my evaluation. When I'm commencing high doses of steroids, I'm looking at screening bloods, I'm excluding infection, TB, doing chest x-rays, looking for TB. I'm asking about a travel history, a psych history, whether they've had significant depression or mania in the past that's going to be exacerbated by steroids. We all know about osteoporosis and steroids, diabetes and steroids. I'm considering pneumocystis prophylaxis. I have a discussion about patients about their risk of COVID, and I also discuss with them the availability of treatment for COVID should they develop infection and the need to start it within 5 days of onset of symptoms. I discuss timing of vaccinations in relation to steroids, and I recommend flu, pneumococcal and coronavirus vaccines, and if they're over the age of 50, consider having the new Shingrix vaccine. So as an ophthalmologist, you're ticking most of these boxes. I have no problem in you prescribing steroids for prolonged periods, but if you're more to the Red Cross side of the equation, then perhaps you should be referring these patients on for further evaluation. So what do we do with patients that have failed steroids and still have ongoing active disease? This is similar to the paper or the slide that JJ presented, and there are a number of approaches. I can get access to mycophenolate, obviously steroids. We can get access to rituximab. I've not tried to get access to Teprotumumab as yet. We clearly can get statins, we can get tocilizumab. And I was pleased to see on this slide that hydroxychloroquine was on the slide. Hydroxychloroquine is one of the favoured drugs by rheumatologists. It doesn't need that much monitoring, doesn't cause infection, doesn't increase the patient's risk of malignancy, it lowers sugars. So all in all, it's a very popular drug with rheumatologists. And there was one paper showing experimental evidence that it can affect orbital fibroblasts to decrease cytokine excretion. So maybe there's a role for using combination therapy with hydroxychloroquine with some of our other drugs. So what are the second-line agents that have been recommended by the European guidelines? Again, I'm sure we're all familiar with these. So we've got cyclosporine, azathioprine, radiotherapy, monoclonal antibodies and teprotumumab. So this is my pre-immunosuppression workup, similar to what I've talked about with steroids. We're doing screening investigations, we're excluding infection, which excluding hepatitis B by doing both the hepatitis B surface antigen and core antibody for patients receiving rituximab is very important, as there is the occasional death from reactivation of hepatitis B with rituximab. And I do chest x-rays looking for TB on most of my patients. I warn patients, given rituximab and also mycophenolate, particularly if they've got lupus, about the small risk of progressive multifocal leukoencephalopathy. If you want a reference for immunosuppressive agents, I would recommend that you consider looking up the Yorkshire Rheumatology Guidelines, and most of the drugs are presented, and they're presented in this format with indications, screening investigations, pregnancy advice, etc. So it's a useful reference. So what about the evidence for non-specific immunosuppressants for thyroid eye disease? And again, there's been numerous studies done, but most of them are very poor quality and in low numbers of cases. We're familiar with response rates for intravenous steroids and oral steroids of around 70 to 80% for intravenous steroids and 50% for oral steroids, but with more metabolic effects from the oral steroids. So intravenous methylprednisolone is preferred. Cyclosporin was studied way back in 1989 and did not show benefit as a single agent, but did show benefit in combination therapy. Azathioprine in one study showed no benefit versus placebo, but in another study, when combined with steroids and orbital radiotherapy, did show benefit. Mycophenolate has been studied in a number of studies, and has shown benefit. In this study, it was superior to steroids. In a meta-analysis of 6 studies, the combination of mycophenolate and methylprednisolone fared better than methylprednisolone alone. And in the Mingo study out of Europe, again, showed that the combination therapy with methylprednisolone and mycophenolate was better than methylprednisolone alone, but it wasn't a significant result, so there was a trend. But overall, if you look at this slide, there tended to be better outcomes when combination therapies were used. TNF inhibitors have not taken off really in thyroid eye disease, and the studies have been small numbers. Rituximab, JJ spoke briefly about these. There were 2 studies, one out of Europe and one out of the Mayo Clinic. The Mayo Clinic showed no benefit, but the study out of Europe did show benefit. But there was a difference in disease duration and steroid use. So we're talking about a disease duration of 4.5 versus 11 months. So was the outcome better in the European group because they were treated earlier? Tocilizumab, again, has shown benefit in some studies. One of the interesting things in this study was that the placebo response rate was 60%, but tocilizumab was superior at 16 and 40 weeks. So there's reasonable evidence for tocilizumab being an effective drug in this condition. So what about access to these drugs and their costs? So I can get access to selenium, oral steroids, intravenous methylprednisolone, mycophenolate, azathioprine, methotrexate, cyclosporin fairly easily. Their cost is quite reasonable. The cost of intravenous methylprednisolone over about 12 weeks in private costs around about $4,000. With tocilizumab, I can get it for rheumatoid arthritis, giant cell arteritis and juvenile idiopathic arthritis, but it's much more difficult to get it funded for treatment of thyroid eye disease, and the cost works out at about $4,000 for 6 months for the drug plus infusion costs. Rituximab has, as of the 1st of September, has gone on to the PBS as a highly specialised drug, so I can now get access to it for costs for the patient of $42.50 plus infusion costs. That will change our availability significantly in being able to get patients onto rituximab. Teprotumumab, the course for 8 treatments I worked out in Australian dollars is $562,000, so I suspect it's not a drug I'm going to be able to easily obtain. And orbital radiotherapy will cost about $22,000. At Cabrini, where I work privately, the out-of-pocket cost for the patient is of the order of about $1,600. So Teprotumumab in Australia, it's not TGA approved, it's unlicensed. If you wanted to prescribe it, you would have to apply to the TGA. It would be a Category B SAS drug. The responsibility would fall onto the physician prescribing it, and you would also need to apply to the Office of New Drugs, which is based in Sydney to import the drug. Would private health insurance cover the cost? I doubt it, mainly because it's not been compared to standard therapy, it's only been compared to placebo. And this is just how I calculated the cost and came out at the figure of $562,000 for the course of treatment. Laszlo Hedgidis, who is the president of the European Thyroid Association, raised some concerns about Teprotumumab as to whether it's financially sound. He didn't say it wasn't, but what he said was that it may turn out to be the cheapest drug, but we just don't have the data. But we also don't have good data for other treatments such as rituximab, tocilizumab, mycophenolate and steroids. And a direct comparison has not been done with intravenous methylprednisolone and would have been ideal if that had been done. We lack long-term recurrence rates and cost effectiveness, and there's lack of defining phenotype, severity of thyroid eye disease, which merits treatment with this drug. And I was intrigued to see this comment from the authors of the Optic trial, where they said that B-cell depletion with rituximab was very expensive, which compared to $560,000 a year, I found a little bit of an odd comment to make. I'll skip over the COVID issues, but I'm happy to answer questions on that if asked. So in conclusion, there's a subgroup of patients that I see that don't do well with current standard therapy. We need better biomarkers that predict poor responses to therapy so that an early switch in therapy can occur. We need better studies of current therapies and perhaps need to consider combination therapy earlier in patients with poor prognostic markers and severe disease. And it's hard to justify a price tag of 500,000 Australian dollars for Teprotumumab in the absence of robust pharmacoeconomic data when compared to current treatment, particularly pulse steroids. Thank you.
Thanks, Tim. That's an excellent talk. I now realize that hydrochloroquine might treat thyroid eye disease, but not really proven in COVID. So that's something new for me. Well, I've just got a little comment from the live Q&A sessions that there's no sessions online, or the session is not live streamed. But if you have any question, please don't hesitate to put them down, and we will discuss it after Tom's talk. So Dr. Tom Hardy is the head of Orbital Plastics and Lacrimal Unit at the Royal Victorian Eye and Ear Hospital. He has major research interests in oculoplastic and has published widely with more than 60 papers and 4 book chapters. He's a co-investigator for thyroid eye disease clinical trials. He's going to talk to us on the update on diagnostic testing for this thyroid optic neuropathy and its management.
Thanks very much, JJ, for organising this symposium and for the invitation to speak. So I'll be talking about dysthyroid optic neuropathy, or DON, to save repeating those 3 words excessively. So I think we all know that DON is relatively rare, but in centres like the eye and ear, it's a relatively higher proportion of patients that we see and treat. And it's important to know and to recognise that it can be severe and can be permanent. Diagnosis can be difficult, particularly if it's bilateral, and we don't have any really clear diagnostic criteria. The risk factors are pretty well known, but most of these are not modifiable. It can develop and progress over time, sometimes after a prolonged period of time. And in addition to thyroid eye disease being associated with a poorer quality of life, this is particularly so with dysthyroid optic neuropathy. So how do we define it? Well, it's a little elusive, but these two, the European and the Australian definitions, all include the obvious clinical parameters of acuity, colour vision, field defects and so on. And both of them also include radiological measures, which are important and we'll come to. And the theories behind the pathogenesis are also not entirely clear, but I think that we have pretty much settled on microvascular compression and ischemia as the primary presumed pathology or pathogenesis. There are conflicting relationships to proptosis, whether those with more proptosis or less proptosis are at greater risk or not. But the extraocular muscle and fat enlargement is thought to cause an increased hydraulic pressure. That increases the resistance to flow in the ophthalmic and central retinal arteries, leading to reduced vascularity in the capillary networks in the in the retina and choroid, particularly around the fovea and the disc. There's also the possibility that there is direct compression of the nerve from the enlarged muscles, impairing axonal flow, and the other possibility is that there is an inflammatory type of optic neuritis from the free radicals and cytokines. Optic nerve stretch is probably an unlikely theory, as espoused in the recent paper by Jeff Rhodes and Kavya Vadani in Moorfields, and we also need to consider glaucoma as a possible differentiation. So the risk factors and associations for dysthyroid optic neuropathy are quite well known. The older patients are known to be worse, and JJ's study showed that there's a roughly 60% increase in the risk odds ratio per decade as you go up in age. Smoking is well recognised. Being male is also a well recognised factor, and ocular motility restriction and angle of strabismus deviation are also recognised as being significant risk factors. Active disease, of course, is more likely to be associated than inactive disease. Ptosis, and also diabetes and other microvasculopathies, as you'd expect, are associated with this condition. The TSI theta has also been shown to be a risk factor, even in cases that are thought to be clinically inactive. And recent study has shown that there's probably an association with obstructive sleep apnea as well. So the clinical findings are pretty well known. Patients may or may not complain of blur, but the majority of them will have some reduction in visual acuity, but a high proportion will have a vision of better than 6/12. They may also have obscurations of vision, which may be postural or not. Colour vision is classically reduced in about 2/3 of patients, but often defects in the blue-yellow that we don't test with the Ishihara, these are more sensitive markers of optic neuropathy than red-green. Brightness and red perception will be reduced, or may be reduced if it's asymmetric or unilateral, and contrast sensitivity may be reduced as well. You will only find really a relative afferent pupil defect if it's unilateral or significantly asymmetric, so watch out if there's no afferent. Of course, I'm sure you're all aware of that. And as I mentioned before, ptosis and reduced levator function, as well as reduced ocular ductions, are common findings. The disc is often normal, but may be swollen in up to half. And in those patients, they may have a worse response to steroids. Disc pallor is pretty rare and is usually quite a late finding. And also just be aware that inflammatory findings may be fairly minimal. So what tests can we do to help us pick it up if we're not sure, if you've got a bilateral patient? Well, the visual field and OCT and imaging are readily available and commonly utilised, but I'll just discuss a few of these others briefly. So firstly, visual fields. Visual field defects are quite common. More than 2/3 of patients will have some sort of finding. Most of the studies report the results from Humphrey visual fields, but frequency doubling is also a relatively effective and can be pretty sensitive screening test if they have good visual acuity. The most common finding is an inferior visual field defect in about half of the patients that were studied in this American paper. But others are also seen, and each of those are much less frequent compared to the inferior findings. And using the ocular hypertension treatment study classification of field defect types, most of these were in the other category, and of those, most of them were inferior. So really highlighting the finding of inferior field defects. And why does it affect the inferior fields? Well, one of the theories is that with increasing orbital apex congestion, the superior rectus levator muscle group is thought to exert more of an effect of compression on the optic nerve, particularly at the apex, as the superior rectus tends to thin out less as you head to the apex compared to inferior rectus, as shown on that diagram there. And these are the stages that are described from that paper by Susan Freitag, in trying to sort of document the progression of field changes in optic neuropathy. And they've also shown that, as you would expect, that without treatment, visual field defects progress, and with treatment, they can regress under certain circumstances, namely determined by the OCT. So the OCT, the real key things we want to look at on the OCT are the nerve fibre layer, and in the early stages, it's often swollen, and the degree of thickening correlates pretty well with the severity of the DON. And as I mentioned before, a late finding is thinning of the nerve fibre layer, which is associated with a poor prognosis to treatment, poor response to treatment. We also see the choroidal thickness is increased in active disease, And an early finding, which is very useful, is looking at the ganglion cell layer, which can show thinning in the absence of any other field or OCT changes. So it's worth checking that as well. OCTA, not a standard imaging modality that we use in the orbital clinic. Again, it's shown that there's an increase in the choroidal thickness shown in patients with thyroid eye disease, and also the foveal avascular zone is larger in patients with active thyroid eye disease compared to those with inactive disease and controls. And the radial peripapillary capillary networks are reduced in diameter in DON patients, more so than thyroid patients without DON, and again more so than patients with controls. And this correlates pretty well with the visual field defect. Now, electrophysiology is something that we don't use routinely at all. However, it is a very sensitive indicator of DON, so worth considering if everything else is negative, which would be a bit surprising. But in 94% of patients, it's been shown to be abnormal. And the typical findings are a delay in the P100 latency and a reduction in the amplitude of the P100 wave. And one paper showed that if you look at the N75 P100 amplitude for a 15-minute visual angle, this is very sensitive and highly specific marker and distinguishes between DON and glaucoma. Don't ask me to tell you too much more about electrophysiology. Radiology, very important and common findings. As I mentioned, orbital apex crowding, we're all familiar with that from enlarged orbital extraocular muscles, and we can measure the muscle index. A muscle thickness index of greater than 50% is thought to be a pretty common finding. Enlargement of the levator and superior rectus complex, as I mentioned before. One paper showed that enlargement of the medial rectus itself was a very specific indicator of DON. And another paper has shown that tendon enlargement is found more commonly in DON. Other findings that we might see are dilated superior ophthalmic vein, a narrower bony orbital angle at the apex, which is probably an anatomical predisposition to DON, prolapse of fat intracranially through the superior orbital fissure and lacrimal gland prolapse forwards, and also increased perioptic nerve subarachnoid space. So just showing that we work out this extraocular muscle index or Barrett index as a proportion of the vertical height of the orbit that's occupied by the vertical muscles or the horizontal width occupied by the horizontal muscles. And when you work that out as a percentage, if it's greater than 60%, then you should have a high index of suspicion for DON, but it's not diagnostic. You have to consider all the clinical factors as well, visual fields and OCT. Now, MRI, there are a number of papers looking at MRI and DON specifically. Muscle index is shown to correlate quite well with DON as per the CT studies. Also, what's been found is an increased T2 signal within the optic nerve itself, and you need pretty good quality MRIs to see that. Also an increase in the water fraction, and on diffusion tensor imaging, the water diffusion in the optic nerve are associated with DON. Also the diameter of the nerve itself, not surprisingly. However, one interesting finding in one paper was that the CSF space around the optic nerve, if that's dilated, that's also quite a sensitive marker for optic neuropathy. So how do we treat it? Well, I think it's important before we embark on the treatment, it's been alluded to in previous talks, is what's the time course? Are we catching it early in the disease or is it late? Has it all burnt out? How severe is it? I mean, you might consider possibly not treating it if it's at end stage and not terribly severe, but if it's progressive and active, then you're certainly going to have a lower threshold to treat. And the treatment should be individualised to the patient, of course. General measures are really important. Get the patient to stop smoking if they haven't. Get them to be euthyroid. Consider selenium. I haven't really seen anything talking about selenium as an additive benefit in dysthyroid optic neuropathy, and of course treat the pressure if it's high. So the mainstay of treatment for DON is steroids, orbital radiotherapy perhaps, decompression, and possibly other medical treatments. And we've discussed the steroid treatment for moderately severe disease, but for severe sight-threatening disease, they call it very severe, it's intravenous methylprednisolone, half a gram to 1 gram for 3 doses, either on consecutive or alternate days. And then what's recommended is that you review the patient after a week. If there's been no response or they get worse, then they should go straight for an orbital decompression. If there is some response, then you'll treat again, same dose, a week later. And if then there's only partial response, you might consider an orbital decompression then. But if the patient does respond, then you would then go down the line of the moderately severe treatment of 500 milligrams a day for a week, considering, of course, the total dose remains under 8 grams. So that's the standard treatment that we use at the Ioneer Hospital. There have been some reports to suggest that if you have disc swelling, the methylprednisolone is less effective. I don't quite understand that. If you have a higher CAS score, the steroid treatment may be less effective, or if you have severe field defects, again, the steroid treatment may be less effective. And if someone can't have, for some reason, IV steroids, you could consider orbital steroids. There's some modest benefit in a relatively small number of series there. Orbital radiotherapy for DON is not first line, and there are some variable results which probably relate to patient selection, activity and duration of disease and onset of disease. However, the standard treatments that are given are 20 Gray given as 10 fractions, so over a 2-week period, but one paper suggested giving 1 Gray as 20 fractions, so 20 fractions of 1 Gray as being as effective and less side effects. The possibility of low-dose radiotherapy, such as 2 Gray, that has been shown to be used as effectively in orbital lymphoma is another possibility. Steroids should certainly be given during the course of orbital radiotherapy. Orally is fine. And there was a paper from Peter Dolman's group in Canada which suggested that radiotherapy may be protective against DON. So that's another thought. Other medical therapies, really nothing that is standing out here. Most of these studies are relatively poor quality. None of them have been randomised. Mycophenolate was shown to have some efficacy, increased efficacy when given in conjunction with IV methylprednisolone for DON, but the numbers were pretty small and there may be some confounders associated with that. Ugogo recommend avoiding rituximab in patients with DON, but I think it was Tim, or was it JJ who mentioned, no, I think it was Tim that mentioned that there are some papers that show that the DON can actually improve with rituximab. So not clear there, but the Ugogo says no. Tocilizumab, relatively inconclusive. There are fairly small studies, but again, it may be helpful. Teprotumumab, again, small studies, but there was one with 19 patients where they had an early response. So it may be beneficial for non-responders to standard treatment for DON. And interesting, a single case report using diuretics as a possible additional treatment. So just briefly, orbital decompression, I won't go on too much about this, but the indications are basically, as I outlined before, the Ugogo guidelines, if people don't respond or get worse after their pulsed steroids. But really, how many walls you do, which walls you remove, are not clear. There's no clear guidelines on that, but it's certainly important, I think, to focus on the orbital apex, to expand that as much as possible. So getting back posteriorly as you can, particularly on the medial wall, and sometimes probably an endoscopic approach would enable more aggressive apical decompression. It's important to note that it may also be required late in the disease course for people who have a recurrence or a relapse. So there's a paper showing that that can be beneficial even in late recurrences. But overall, it is beneficial, and there are multiple factors that probably affect the outcome of decompression for thyroid eye disease. So I will now sit down and we will take some questions. If you've sent some through on the app, we'll read those out, but feel free to come up to a microphone or speak loudly, and we'll do our best to answer some of those questions. And then we'll move on to some cases that Simon and Raf are going to present.
I might just make a comment first on that point on the rituximab, of it being worsening DON in the moderate to severe group. There are a few cases of active, moderately severe TED patients treated on rituximab, and they develop cytokine release syndrome, leading to worsening of vision and DON. I think it's in the context of the infusion reaction of rituximab that happened. But I think, correct me if I'm wrong, we do give hydrocortisone and antihistamine with rituximab to avoid this sort of situation. it probably stems from that, from the study.
I think it is. Yeah, I agree. There sort of seems to be some conflicting evidence in the literature, but just that's the position on the 2021 UGOGO guidelines and their sort of statement on rituximab.
All right, given that there's no question, we will move on to, I would like to welcome Dr. Simon Taylor to discuss his case for a panel discussion.
Thank you. Well, good afternoon. How do we advance this one?
Green button to go forwards, red go back, and that's the pointer.
Okay, so good afternoon. I'm Simon Taylor. Myself and Raf Ghabrial were going to present some cases. I was going to take a step back and look at some of the fundamental concepts of the assessment. Most of our talks today have been on treatment, but I thought with the audience we'd take some steps back, and then Raf's going to take a step forward and talk about one of his complex cases. And we're happy to take questions as we go. So the first case, and I'm going to sort of stop along the way and ask the panel some questions, was looking at really risk factors for development and progression of thyroid eye disease. Tom Hardy talked about specifically the risk factors for compressive optic neuropathy, but this is for the development and progression completely. So a 34-year-old female, she's had Graves' disease for 1 year, thyroid toxicosis, now euthyroid on carbimazole or neomercazole. She's noted changes here in appearance over the last 3 months. Her vision's good, no double vision. As you can see, she has some eyelid retraction, proptosis. She gets morning swelling, but it usually settles by about 9 in the morning. She has a family history of Graves' disease. She's a non-smoker. She comes along and sees you for the first time, and she really wants to know what will happen. She's seen the pictures on the internet, like we all have, and she doesn't want to go blind. She's frightened. So the question I have for the panel in this case is, from the first patient encounter, can we predict the expected disease progression? What are the risk factors for the development and also the severity of thyroid eye disease? JJ, could I ask you? You did some work a few years ago on the risk factors in the Australian population.
So the risk factors to look at in the patient that first presented will be how old are they? Are they sort of, the patients who are older, typically above 50, tends to have the risk factors of developing more severe disease. The second risk factors will be, are they a smoker? The smokers tends to have double the risk, if not more, of developing thyroid eye disease and being more resistant to treatment. Other risk factors include whether they have previous radiation iodine use. There is a risk factors for triggering thyroid eye disease, not necessarily having more severe progression. Other biochemical markers will be looking at whether their TSH receptor titers is high or low. Typically, patients who have very high TSH receptor titers will be looking at them having sort of more adverse outcome in severity prognosis. This is especially with the third generation and TSI measures that has come on in the last couple of years. I suppose the other thing is a thyroid function, whether they are currently euthyroid or if they have hyperthyroidism. The T3 toxicosis tends to be associated with more severe disease also.
So I've sort of collected a list here over time for both the risk factors and risk for the development and also the severity. Some of these are obviously modifiable, and I'll just point out for a few. Obviously, you've said increased age, the duration of the hypothyroidism. Smoking is always a challenge for all of us. Genetic predisposition, females, because Graves' disease is obviously more common, even though it's more severe in men. Ethnicity, the studies are consistent. It often depends on the genetic studies, how much thyroid, iodine's in the community, and those sort of issues. Drugs, as you said, radioactive iodine. There's another drug, alemtuzumab, used for MS. Have you come across that? I've seen 2 patients with that develop.
Yes, coming across where they're, because it is an immune therapy, and therefore it causes dysregulation of the immune system and triggers of thyroid eye disease. So there's a known risk factor for TED.
Right. Antioxidants, and particularly the one we hear about is selenium levels. We often prescribe selenium for 6 months. Is there benefit in keeping it longer? Is this going to change the course, the development in patients?
It probably has its use for the sort of mild soft tissue involved thyroid cases. There was currently no evidence of extending it more than the 6 months. And the rationale for its use is not so much as to correct deficiency, but more as mainly as an antioxidant.
Yeah. And Dr. Godfrey, I've mentioned here low vitamin D levels, and also, as we've mentioned, high cholesterol, and also statin use. Are these things that you look for in patients?
Yeah.
Yeah.
In other autoimmune diseases, particularly in lupus, vitamin D being low is meant to be a risk factor for disease activity. So certainly there are a number of advocates for making sure that vitamin D levels are normal in autoimmune diseases. The statin use has been raised as a bit of a problem. It's, atorvastatins and statins in general have been associated with autoimmune diseases such as autoimmune hepatitis and necrotizing myositis. So you've already got one autoimmune disease and we're adding in a drug that potentially might cause others. So I think statin use would have a bit of a question mark still over its use. But I'd be very interested in using, should we be looking at in someone with mild disease, a statin, hydroxychloroquine, methotrexate and a short course of steroids? Don't know the answer.
And obviously for the disease severity, there's similar risk factors. That raises the question, should we as ophthalmologists engage in a discussion with the endocrinologist about the best treatment? Tom, what do? Do you write to the endocrinologist and...
I'm sorry, about the thyroid treatment?
About the thyroid treatment.
Well, I do. They sometimes ask it, and I do sometimes discuss it, and I will always mention radioactive iodine as being, in general, associated with the increased chance of progression or development of new thyroid eye disease. But a bit more of a nuanced discussion would take into account their risk factors, which a lot of these are listed here, and she's in a pretty low risk group. But I also do mention the American retrospective health data information study, which showed that there was some protective effect from thyroidectomy as opposed to medical treatment in developing thyroid eye disease. But so that's, not strong evidence. I'm not sure if there's anything more recent on that.
And finally, in the initial assessment, do we look at the TSI levels, the TRAB levels?
Yeah, we do.
And how does
I think
it help?
most endocrinologists are pretty good at checking that. Sorry.
But do you use that as a clinical indicator, the higher TS level, or is it case sensitive? Do you follow it over time?
I think it's in context of the actual absolute level, what's happening to that level over time, how well controlled they are from a thyroid status and all their other risk factors. But I've got one patient who has the highest, she was like, I had a TSI of about 200, which I haven't seen before, and she's finally settling down. Any other comments from Raf?
And the normal's less than...
I think to answer your question, that the patient comes to you saying, how long is this going to last, doc? What's happening? I don't want to look like these people on the internet. I mean, the only number I have for them is 18 months would be average. You might be a 6-month or you might be a 4-year, I don't know. But when I see you for a second time, we'll be able to determine whether you're on the upswing or the downswing. So, and all these modifiable risk factors certainly need to be discussed. And TRAB is part of that, exactly as Tom said.
All right, so I don't have another picture of that woman, but when would you tell her to come back for her next check, for a review check, to try and estimate or guess the trajectory of change?
6 each eye, nothing to concern me. So I'd say 6 to 8 weeks for that lady.
JJ?
Yeah, it tends to follow them up over 3 months to see if they have any progression. In terms of the TSI as well, currently our TSI assay isn't 100% correlated in terms of its linearity with progression. So I probably won't take too hard of a stance to say that you actually have to trace them over time, but just having an idea about how immunoreactive they are at diagnosis and at certain time of change in treatment.
Right. The zeitgeist of thyroid eye disease.
Can I ask, would you use an MRI in this patient to guide?
I might hold that question because we've got case 2 coming up, so we'll have a look at that question if you don't mind me interrupting. So this is more about the assessment in the patient. So 53-year-old gentleman, Graves' disease, diagnosed late 2020 1, he presented several months later. He's got sore red eyes, noting change in his appearance, and there he is here, coming into your office for the first time. His vision's good, no optic neuropathy. We've looked at his field of binocular single vision. He's got double vision, more than 15 degrees in upgaze. Pain and eye movements, exop thermometry measurements are stated there, and he's got classic features of Graves' orbitopathy with lid retraction, but he also has some inflammatory changes, lid swelling, chemosis, a little bit of exposure keratopathy. Can I ask the ophthalmologist on the panel, how do you assess and document orbital inflammation? There's been a few scoring systems used, some for studies, some more historical, Ugogo, Visa, no specs, those sort of scales, and I'll show you a few in the next slide, but just tell me about your personal nuances in an assessment. And I've drawn up here just the markers of inflammation. There's 3 scales. The audience might know Ugogo, the Visa, the no specs classification.
A lot of
work at the group at PA. How do you document?
We tend to use the Ugogo, but as you can see, there's a lot of crossover with Ugogo and Visa, so I think you pick one and stick with it. Doesn't matter which one. And then no specs is pretty old hat. I mean, that's 30 years ago, and I don't teach that to any of the trainees now. So Ugogo seems to be good because you've got those last 3 marks out of 10 for progression, which I guess talks back to the last case as well.
Right. Tom?
Yeah, I mean, the CAS score is pretty quick and easy, and most people are familiar with it, and so I think it's appropriate then. I mean, if you're going to use something, that's worth using that. The Visa Inflammatory Index is a bit more complicated. It's probably a bit more nuanced. It's not purely binary. We use that in the clinic at the eye and ear. So I'd prefer the Visa, but in practical terms, the CAS is a bit easier.
JJ?
I don't know if you remember at the beginning of the year, we sent out a photographic survey for the Visa inflammation scoring. And the Visa inflammation scoring have a 90% or above 90% correlation in terms of inter-observer changes. So I think whether if you use CAS score or Visa inflammation score, they are quite reliable.
Right. And one of the things a Visa does is it has that diurnal variation, which I find quite useful to assess progression. And I'd be interested if there's other thoughts in the audience over time. Here's that question on MRI scans. Here's one study, the evaluation of the activity of Graves' orbitopathy using the STIR sequence. Obviously, that looks at the signals from the fat. It suppresses fat signals and reveals a high signal intensity in the fluid-filled tissue, such as the muscles. Is that a useful tool? Do we use that in addition to the clinical assessment? Or is this more of a research prospect at the moment? Tom?
Yeah, I think it's useful. I must say I don't use it a lot. I find that the clinical activity, measuring the clinical parameters is usually satisfactory, but there are some patients, like particularly with thyroid optic neuropathy, where they may look inactive, and I think this is really useful in that. Plus you get all the muscle index and other indicators as well. So it's certainly not routine in my practice, but helpful in cases where it's a bit unclear.
Yeah, Dr. JJ?
I find that useful in certain cases. For cases who have progressive strabismus, but have little inflammation sign, I would do an MRI looking for muscle inflammation to decide whether I should pulse them with steroid or add a mycophenolate. Or for patient who has reduced vision suddenly and looks inactive with severe proptosis. We had a patient, I think in the last 2 years, who had chronic thyroid eye disease, proptosis of about 28, good vision. After a complicated sort of cataract surgery, suddenly lost a lot of vision in one eye, like 660 or count fingers. Looks totally inactive. Or the MRI shows up unimuscle T2 hyperintensity. And on that basis, we pulsed her on steroid and her vision recovered.
Right. Dr. Godfrey, did you have another thoughts on the scans, or you had a question before?
Well, I'm always sort of wondering if we can get to these patients earlier with treatment, whether they're going to do better. And I'm just wondering whether the MRI would persuade you to as ophthalmologists to refer earlier or to look at combination therapies earlier. In the first patient that had mild disease, would an MRI alter your management if you showed significant muscle inflammation?
I think it probably would, but I think you're right. We don't really know, well, from my experience anyway, that if we did lots of MRIs on these people, whether we would start the treatment earlier. That's a good point.
Raf?
I think it's a fantastic modality, and we were using it in the 90s in Bristol at stir sequences, and it was published back then. And then I didn't hear anything about it till the last couple of years. But you can see how waterlogged the muscles are on slide right. And that, to me, tells you direct activity, and I've seen differential muscles be involved. So personally, if I was to make an activity score, which I won't do to splint away from our colleagues, but if I was to have my own score, I'd like to see TRAB in there and waterlogging, and the neuroradiologist can actually give you a score out of 10 or 20, whatever you'd like, for waterlogging, which is inflammation.
Right. This is one of the visa score. It's the follow-up score, which is often used, available on the internet. And up the top, you can see a smiley face and an unhappy face. It says quality of life next to it. Should we incorporate quality of life assessments into our daily practice?
Yes.
Yes, yes, yes,
We
and yes.
have incorporated quality of life assessment in our clinic databases. So all the patients got asked by the orthoptist.
Okay, so that's just a very simple Likert score on the visa, but there's more sophisticated tools, and one you can download from the internet is the Ugogo score, and it does have the nuances of regional change. You'll notice it was developed in the Netherlands, and so hopefully you can see the first score is actually a question about bicycle riding because it was developed in Holland. Tim Sullivan has had to leave us, I think, but he looked some years ago at the Australian community and found it useful as well. Thank you. Raf, I think you've got a case as well. How do we come to
Yes, I'm going to invite our fellow, Marlo, from the Philippines, who spent 5 or 6 months with us, to come up and present a case which will dovetail very well with Tom's talk about dysthyroid optic neuropathy. And this lady just presented to us in the last couple of months, and we saw her last week as a final, not a final follow-up, but as our latest follow-up. Thanks, Marlo.
Could we go to Raf Ghabrial's talk, please? Thank you. Yeah, that's too advanced. Let's go back.
All right, so good afternoon. We're here to present a recently managed case of DON. So we have SC, a 51-year-old female, known history of thyroid eye disease, who presented with blurring of vision, more on the right than the left. 2 months prior, she received IV methylpred infusion for 6 weeks for vision loss at a regional hospital. However, there was minimal improvement. Hence, she was referred to our center. And these are her past medical, ocular, and social histories. During initial consult at our center, she presented with reduced VA and color vision on the right eye, with RAPD and elevated IOP, but normal-looking disc. She has 2 millimeters of proptosis in the right eye, ocular restriction, but without diplopia, and a CAS score of 6 out of 7. Visual field demonstrated inferior arcuate scotoma, more on the right eye, and on OCT, there's normal RNFL thickness and ganglion cell count. CT scan revealed right eye proptosis with moderate enlargement of the recti muscles and apical compression seen more in the right orbit. So given the clinical and diagnostic findings, our diagnosis at this point was DON, and urgent orbital decompression was advised, but the patient refused despite warnings of that this may progress to a permanent vision loss. So in keeping with the updated UGOGO guidelines, a high dose of 1 gram IVMP was given to her for 3 consecutive days. And after the first cycle, significant improvement of symptoms was noted, indicating good response to the high-dose IV pulse steroids. And following UGOGO's algorithm, another cycle of 1 gram IVMP was given to her 1 week after, And at this point, the patient feels like she's back to normal with a CAS score of 3 out of 10. However, 2 weeks after the treatment, she came back to a regional center due to worsening of symptoms, and now she presented with a sudden reduced vision bilaterally with the recurrence of RAPD in the right eye and a CAS of 8 out of 10. So CT images on top were before presentation at our center, while the images at the bottom were taken after treatment with 2 cycles of 1 gram IVMP, showing significant enlargement of the recti muscles and more apical compression now seen bilaterally. So now the plan was to do an urgent orbital decompression to her, and we performed an endoscopic approach. 1 day post-op, the vision significantly improved with reduction of proptosis, and the patient did not complain of any orbital pain or diplopia. 2 weeks post-op, she remains asymptomatic and vision is stable, and the orbital CT shows right eye, medial wall, and some floor decompression with herniation of orbital tissues. And currently, she was started on oral prednisolone 75 milligrams per day and will be reviewed in the coming weeks. So I guess some of the questions that we have for the panel and for the audience are the following. So number 1, do the UGOGO guidelines for steroids in DON reverse severe disease? And in terms of disease activity, is there a place for investigations including MRI and bloods? And what is the reliability of exophthalmometry? How long does it take for vision to improve after decompression? What is the recommended number of orbital walls to decompress for DON cases? And lastly, what is the duration of oral steroids post-decompression? Thank you.
Thanks, Marlo. It's convenient. There's about 5 questions there, and there's 5 of us up here. So, Tom, would you mind speaking in the next 2.5 minutes to the first question? What's your experience with these UGOGO guidelines for steroids? Like, have you reversed someone? Have you found a patient come in at 6:24, given them the IVs and gone, wow, great news, goodbye, it's all over? Or do they usually end up at surgery?
Not always. So actually, JJ might, the numbers are fresher in her mind because we did look at that. Do you want to just talk about the results of that study?
We're actually going to discuss this result at the oculoplastic free paper session tomorrow.
Okay, I can wait.
But generally, we get reversal of DON only in about 40% of cases.
40%.
Yeah.
Because it was really interesting with this lady who wouldn't have decompression at the first visit, that you saw how her muscles almost doubled in thickness in less than a month. So, and that was with a huge dose of steroids. Like, she had a total of 9 grams, like over the recommended dose. So, just interested, 40% would be my experience, but I haven't got the numbers to back it.
Yeah, I mean, the published figures are a bit higher, more like 50, 60, I think.
Yeah.
Okay. So possibly a good one for Tom, and I think he was asking the same. Sorry, for Tim. This Tim. There's too many Tims and Toms. Is there a place for investigations like in inactivity? Like if we could have an objective score for MRIs and we already have TRAB, because I don't trust my trainees with reliable exophthalmometry, not because they're not good eye doctors or precise people. I don't trust the exophthalmometer, as was discussed by one of our colleagues yesterday in our craft meeting. Any thoughts on that, Tim?
Look, I haven't studied all the literature on MRIs, but there certainly seems to be a place for it in assessing people with severe disease or and even when you look at clinical activity scores, sometimes the MRI will pick up disease activity when your clinical activity score is not helping you. So I think there probably is going to be an expanded role in the future for using MRI to assess some of these people. And the same goes for the TSH receptor antibodies, is that it doesn't always correlate with their degree of orbital activity as determined by things like MRIs. So I think there probably is a role for further investigation in these people.
Thanks. Can I ask anyone on the panel, or everyone on the panel, how long they think it takes for vision to improve after decompression, if it's going to improve? And do they think it's related to axoplasmic flow, as mentioned in Tom's talk?
I think it usually improves pretty quickly within a week or two.
Yep.
If it doesn't, I'd be worried. And if they've had the quotes full course of IV steroids, they haven't responded to decompression, you think get another scan urgently, see if you've done enough decompression at the apex, and if you haven't, you might need to go back and do a bit more, or consider referring them to radiotherapy.
In this case, though, I would recommend that, with the scan, she'll probably need another lateral decompression and decompression of the floor, and including the posterior strut. So maybe even getting an ENT surgeon to decompress at the far apex as the next things to do.
No, we'll see how we go. Hopefully she's on the mend. But I guess you've answered the question 4. How many walls do you decompress? And then Simon, any comment on the duration of oral steroids post-decompression? You just titrate that, I guess?
I guess you titrate it. Probably 2 weeks, but then you've already given them intravenous steroids, so you might want to finish off that course. And as you mentioned before, if they're at the surgery, of course, just expands the orbital cavity, but doesn't reverse inflammation. So that's where maybe continued steroids or even the thoughts of post-decompression orbital radiotherapy may have a role. And they'll probably get some steroids again to prevent that late recurrence. And some of the features that we see in patients with questionable optic neuropathy are probably from vascular congestion, and the decompression helps that, which the radiotherapy won't.
Yeah, although there was one paper which suggested that surgery does reduce the inflammation, orbital inflammation, but distinguishing that from congestion could be really difficult. So
yeah, I think Vic Goldner's paper looked at early decompression, and it seemed to reduce the long-term inflammatory changes.
Yeah.
Well, we're 2 minutes over time. Marlo, do you have time to come and just go back to the post-decompression slide? If you can just find that, it might be of interest to the audience, and certainly after what JJ said to us, for us to discuss walls and herniation and effacement and all those things which I don't always understand. So slides. I guess we feel we went quite far orbital apex-wise. We took half of the floor endoscopically, and I acknowledge for sure that we may need to go laterally. My thought is that the lateral wall is not as directly involved in thyroid optic nerve compression, and I think Tom mentioned that in his, but there are papers that say it's as effective as medial wall decompression. Just wonder if the panel would like to talk around that just for a couple of moments.
Yeah, I'm not sure. I couldn't get a clear answer on which walls you should decompress and how many, but yeah, focusing on the apex is the key. And I think you're right. Most of that angle at between the medial wall and the lateral wall is there's kind of relatively more space posteriorly in the lateral orbit. But I personally would decompress the lateral wall as well as the medial wall, and usually a bit of medial posterior floor for almost all optic neuropathy cases. Just I want to get as much done as I can in the one go. Unless they're not terribly proptosed, I might consider revising that. But that's just a personal opinion, that one.
I mean, if you look at exactly the optic nerve as it passes through the apex, medially I think you're right on the money, because that's where the nerves decussate. Laterally, you can get to the money, but I think you're going to be walking into the middle cranial fossa, which never pleases me. I mean, I know some of my colleagues like to see dura, but yeah, it's interesting and a case of interest. So thank you very much, Marla.
Great. So are there any questions from the floor, from the audience, for any of the panellists? One more chair.
There is a question that comes through the live Q&A session that asks about clarification whether statins is associated with increased risk of thyroid eye or improvement in the STEGO study. So the STEGO study shows that the statin group has improved outcome as compared to IV metoprolol in terms of better response rate with IV metoprolol treatment, better score for quality of life, and reduced recurrence. So in sort of a protective effect. I'll just clarify.
Yeah, and another general risk factor paper I was looking at, high cholesterol by itself is a risk factor for the progression and development. statins reduce the risk by about 40%, but other cholesterol-lowering medications do not do that. So there may be something peculiar about the statins more than just the cholesterol-lowering effect.
Thanks, Simon. And that caveat of Tim's was very useful as well about other autoimmune diseases. So if there are no further questions, no hands. All right, well, I'd like to thank JJ, Tim Sullivan, who had to dash off, unfortunately, Raf and Simon, very much for presenting today, and excellent cases and great discussion, and thank you all for coming. And feel free to please fill out any feedback, and if you have further questions, we may be able to answer them in the break. Thank you.